I struggle with this because I am not a fan of HCG at all. I know some people are, and I always tell people, look, it has a small place, I guess, in a steroid cycle. For me, it's like on a fertility protocol, it's part of it. It's not the main part of it, but it's part of it. What here, it's like when they write you a script at a lot of the clinics, not with the doctor necessarily, but a lot of these clinics, here's what they're doing. Here's your testosterone, here's your HCG, and here's your Arimidex. Yeah. Most people don't need Arimidex on TRT. Some do, but most don't. Most people have no need for HCG whatsoever. What's your opinion on it? What is you guys' protocol or your, how do you tackle that?
So when someone is concerned about their fertility, obviously HCG has a place.
Right.
It sits in this weird area. I mean, we have HCG available. I think there was a problem in the US getting HCG in the past. And so I think it's good to have those things on offer. Now, I know there were some studies about fertility that I think were Baylor College, Baylor University. What was the doctor's name? I can't remember. They made reference to if you want to maintain fertility and stay on TRT, then you add in testosterone, HCG, and anastrozole. And some of the studies will show, I know, that the anastrozole helps preserve the fertility. That's why it's used. And fertility clinics will give it.
Right.
But with all the concern and it's almost a politicization of the anastrozole, because what that's something that I just saw from one of our doctors. He sent me an email. It's something it's not a go-to for us at all. But there are some. It's up to the doctor. There's some patients that may find a benefit from it. And in fact, I've come across a couple of different studies about, and this is going to sound really controversial in the light of this, because I'm not on an AI. I've been on an AI in the past.
Yeah.
But there are some men that may experience erectile dysfunction despite being on testosterone replacement therapy. We've heard of this before, right? You're on testosterone replacement therapy. Everything's on point. Estradiol might be a little bit high, but you say, no, can't do an AI. No, can't do it because, like my friends, some other ones, they say you can't do an AI. And it's become very politicized. And by right, you shouldn't. I mean, in the early days of TRT, there was no AI involved at all. But back then, in the early days, you would mock the doctors, the Kaiser Permanente doctors in the US who weren't writing an AI to go along with your testosterone treatment. And even one of the endocrinologists that saw me, I think, back in the 90s, had written me a aromatase inhibitor, but wrongly at a really high dose. And I'll tell you why, because you shake your head. There are studies that show why does erectile dysfunction happen. So one, it might create collagen in the penis and create venous leakage, even in the presence of testosterone.
Right.
And two, it can increase prolactin in some people when the estrogen gets so high.
Sure.
In some people. So for that small segment, I've seen some of the studies where they've given an AI a small amount or a various different amounts. Sometimes they give too much in the studies. They give way too much. They do seem to solve that problem. I don't know what lots of people say the long term is you're going to have cardiovascular issues, etc. I don't think there's enough studies. I'd like to see them that would show that. But yeah. I think common sense, a lot of people say, well, I don't want to have to be on more medication, full stop.
True.
And that's been the point. But then if you've got a problem and it fixes it, then you think, well, maybe for that particular patient, not crushing the estrogen, maybe slightly getting it into balance might be an option for that patient. If you try everything else, because I don't know what's worse. Do an ergot dopamine agonist, like cabergoline, where you're not sure if that's going to give you valve problems down the road, which it wouldn't, it shouldn't.
Right.
There's no evidence that it would, but there are little blips in the literature.
Sure.
Or aromatase inhibitor. And the problem with the aromatase inhibitors are some of the literature are all based on women who are completely suppressing their estrogen, which is really bad because you need estrogen. And one of the reasons why I don't use the aromatase inhibitor is because, many reasons, but one of them, it can lower my HDL. It can lower your growth hormone level. It hurts my joints. I've got osteoarthritis in both joints, and it feels better when I've not used the AI.
Dries you out, yeah.
But there have been times when I had used the AI, and if I was having issues where the morning erections weren't coming on, a little bit of the AI, you know what? It fixed that.
Yeah.
It fixed it, and it went away. And I think there was a time I wrote it down, just even a few years ago. I looked in my diary, in my calendar, when I did do an AI, it was 1/4 milligram, maybe not even once a week. It would be maybe once a fortnight. It's when the symptoms were coming on, a little bit of that just kept it quiet, brought it down a bit. A little bit of a change kept it, feeling a bit better. So it's a tough one, that. And I hate this topic because it's become so politicized in the TRT community.
Right.
And you often wonder, has it been politicized so that certain doctors or clinics could stake out their claim and say, look, we're different. Or certain people on YouTube say, we're different. We're not doing it like those people. We've got this whole new way. And so I think both sides have valid points. And I did a video with Dr. Anne McLean, some other things, because in the perfect world, and this is what my point was. So we've had patients and the opposite effect. They had low estrogen, despite being on a high dose of testosterone. They couldn't get the estrogen up high enough. So how do you explain that? So the point is bespoke, personalized care. You have to offer something based on that individual. There are some people that don't need an AI at all and probably should never have an AI. Sure. They don't need it. The levels are fine. The sex drive is fine. The erections are fine. They don't get a rise in prolactin. There are other people who might be obese.
That's a good point.
That may in the early days need it. There are some men who might be on finasteride. So they're already doing one blocking the DHT, which you shouldn't do. And if you sometimes don't give them an AI, I see later in the notes, they complain that they got swollen nipples and this, because you've forced it down one pathway.
Right.
So that's where some of the balance, and so if they're already using one poison, you hate to add another, but if you don't, and it's not really poison. I mean, Dr. John Crisley used to say, the dose makes the poison.
Right.
And if you do go overboard with it, you're going to get the bad joints. You may get the bone loss. You probably will get lots of bone loss over time. And I think the goal is to kind of, wean people off with the right protocol. But you know what? Everyone is different. And it's not for, us to judge or decide what is right. We love the cases when there is no AI needed. It's better. And I know the cynics out there will say, oh, well, TRT clinics, they just want to sell more AI. No, we don't. It's cheap as chips. We don't charge a lot for the AI. I was
going to say it's super cheap.
But sometimes I think it's doctor's discretion. And if there is a place for it, it should be minimal. And I'm going to say one other thing. There are some of the gurus out there, some of the doctors who I've even had on my channel that would talk about all the negatives of AI. And we always ask, is it the anastrozole or the exemestane, or is it the medication itself? Or is it how far you've gone to lowering that estradiol over time? I think they can never really pick it apart. But I've had those doctors say, I never use an AI, off camera say, well, there are cases when I have had to use an AI in the beginning for the shortest time possible. So those who think they are, so solid and not veering off to the dark side of the AI world, as it's now been painted in certain online places, that I just think there's got to be a balance, and it's got to be individualized for the patient. And the ideal is not having to have it at all. If you're one of those people that are fortunate enough, but I think I've seen it with myself. I've seen it with other people. There might be a period of time where it might be needed. Now, alternatives could be you go longer without having your next dose of testosterone, right? That should be the last resort. But I think to say completely no in all circumstances, I mean, it's almost sounding like the abortion movement, right? That's in the US, right? So,
yes.
It doesn't matter the life of the mother, just, no. And I think that's, hope I didn't say anything too controversial, but it's just one of those areas where a little bit of flexibility, and it should be little and not very often that you would need it.
I agree. And, I've taken a ton of shit over the years because I am a proponent of controlling estrogen on steroid cycles. And there's so many people, oh, it's going to kill your gains. It's going to crush this. Well, no, not if you use it properly. The thing is understanding your body, understanding how estrogen prone you may or may not be. I can't if I use anything over 200 milligrams of testosterone, my estrogen level immediately goes over 50 into the 60. Like it's way too high.
You don't feel good at all.
No. And I am one of those guys that I know when I see water retention, I flip out.
Or I'm like get puffy or
yes.
And that's the big, go on. Sorry.
Well, you just don't feel right. And it some people don't understand when you get high estrogen, it can cause you to be depressed.
Yes.
And you don't even realize it.
In a different way. I think high estradiol could act on the serotonin receptor. So normally serotonin make you calm, but too much. If you ever had serotonin that gets too high, people on SSRIs, they can't get erections. Or it's a lot harder. So if it's just a matter of doing a small amount of AI in those patients or in people, then that's a different story. I think what happens is there's a conflation that happens in the TRT world. Is that there are some people on a very, very small dose and they probably don't need an AI. And there's some guys that need a slightly larger dose, but then also convert a lot. And the ratio is off because obviously the more testosterone you have, in most people, it's going to make more estradiol, but it's not always the case because I've seen it even in myself when my levels were reaching the trough. I'd still have quite a bit of, 40, 50 picograms of estradiol there.
Yeah.
So, and you don't feel good when it's like that. So how low do you lower the dose and still have an effective testosterone replacement therapy? If you keep lowering it, you still have high estradiol. Now you've changed that ratio in the wrong way.
Absolutely right. Absolutely right. And it's one of those things that's very touchy and it's sensitive to everybody because I swear to you in the bodybuilding community, it is immediately thought of if you use an aromatase inhibitor, you're going to crush your gains. And there's a fine line there.
Yeah.
And it's just like women need small amounts of testosterone. Men need estrogen. And if you crush it, you're going to have problems. And if you go too high, you're going to have problems. So there's that fine line there. I just don't like when it's automatically given. Like, I love the point you brought up about being obese because then one of the things that I run into with guys that they get angry with me when I say you shouldn't use steroids at a high body fat. But one of the main reasons you shouldn't is because you have a higher rate of estrogen conversion. And if you're on TRT, you're going to have a higher rate of estrogen conversion. So I totally understand the concept of an AI there. It makes total sense.
I mean, back in 2016, when we first started and before any of this controversy around this topic had come up, and I think it's dying down, it's becoming more moderate, but it was, and I noticed this in myself when I was younger, you would start on TRT, everything is fine. And then, like I said, 6 months later, what's changed? Okay, estradiol creeps up a bit. People don't feel good. Their bodies are supposed to have changed, but there may be some, negative effects of this. And, when people have been prescribed a small dose of it, tiny dose, if absolutely needed, and we can't change anything else, you do see a change and people are happy and they're not, the libido is good, the morning erections are hard. So,
right.
I think you leave it up to the doctors. We're always trying to give the latest data to the doctors. We're always trying to, and I do this a lot, to find out and say, hey, the less we can use it, the better. But, we can't be so absolutist in our view of this. And as some people are, because just like I said, the opposite is, do we start giving estrogen to men? They can't make any more estrogen because they have a genetic condition where they don't make enough estradiol. And like I said, we've had men that literally wanted estrogen added to their TRT because they weren't making enough. So of the estrogen, because estrogen is beneficial. But massive amounts out of the ratio probably aren't so good for you. And for the prostate as well. BPH, it may help aggravate BPH in patients.
Let me ask you this. Why, I think I know the answer to this, but I want your answer to it. Why is it that it's always anastrozole that's prescribed and not aromasin? Why is that?
Aromasin is amazing on paper.
Yeah.
It's a steroid-based molecule. It's a suicidal inhibitor, knocks the thing out. But it's bloody hard to titrate. And so you don't know how long it's going to be having its effect in the system. There's the half-life bit of it.
Sure.
Then there's the other part of how it's action, basically. So, okay, the half-life of the medications are half the time to remove half of that medication.
Right.
But there's still actions that happen after. So just because the medication's out, you still have now wiped out your aromatase enzyme. With anastrozole, you got this binding to the aromatase enzyme. But it seems in practice it's just easier to control. It's because I've tried both. Exemestane was so hard. Whether you split the capsules or have them, or the tablets, or have them compounded, it's you just can't seem to get it right. Where the anastrozole I think it's just the easiest to manage and control. I mean, you could get away with, I think, a half-life for every 3 days or so.
Right.
Or less. You can do, like I've done in the past, every 20 days, 14 days, and just a little bit to get things down. And then you get that nice estrogen that comes back up. And it seems like the rising of estrogen, the rising of TRT, that seems to drive libido in a lot of people. It's not the static. Everyone talks about stable levels. And I think you can have stable testosterone levels, but then your E2 starts climbing and climbing. And that's what probably, throws a spanner into things so people think stable. I want to feel good all the time. I think that's what people refer to as stable.